Now, let us move on the second topic, which is OSA in adults. This session will be delivered by Dr. Farahani Hassan, an otorhinolaryngology surgeon from Hospital Kuala Lumpur. Dr. Farahani will be sharing on how to screen and diagnose OSA in adults, the available treatment options, and when referral is needed. Please join me in welcoming Dr. Farahani Hassan.
Hi, Assalamualaikum, and a very good afternoon to everyone. Thank you for joining us on a lovely Saturday afternoon. I'm going to continue the next topic, OSA in adults, screening, diagnosis, treatment options, and referral. It is a rather cramped topic combined in one, but I hope you'll bear with me. What are my learning objectives for today? First is to be able to identify the clinical features of OSA, to be able to screen patient at high risk of OSA using the appropriate tools, to be able to diagnose OSA, and to know the treatment strategies for adults with OSA. Next, to learn how to monitor OSA patient and to know how to follow up OSA patient while on CPAP therapy. Lastly, to identify patient for referral to sleep clinic. The general outline of this topic this afternoon is to identify the symptoms of OSA, screening tools available for adult population, diagnosis, treatment, and monitoring and follow-up. Firstly, I would like to start with symptoms of OSA. Adult patients with OSA can present with both daytime and nighttime symptoms as shown below. Daytime symptoms include excessive daytime sleepiness, unrefreshed sleep, tiredness, early morning headache, dry mouth, poor attention and concentration span, memory impairment, mood disturbance, and decreased libido. Whereas the nighttime symptoms, snoring, is usually witnessed by the bed partner or anyone in the family with witness apnea. It's usually not being mentioned by the patient. But the patient may complain of gasping or choking, nocturia, difficulty in initiating and maintaining sleep, and also fragmented sleep, where the patient will have frequent awakening at night. What are the clinical findings of OSA patient? The clinical findings of OSA may include raised blood pressure, having a large neck circumference, obesity, and crowded oropharynx. And how do we assess crowded oropharynx? I will emphasize in the next slide. Micro or retrognathia, which means the patient have small and receding chin, high arch palate, enlarged tonsils, and macroglossia. How do we examine patients' throat? Generally, we use the modified Malampati grading and also the tonsillar grading. So if you can clearly see on the diagram here, modified Malampati is when we ask patients to open their mouth and how well we can see the soft palate, the anterior and posterior pillar, and the uvula. So this is to assess how the tongue sits at the palate. Grade 1, modified Malampati grading, we can visualize the soft palate, uvula, anterior and posterior pillar. Whereas grade 2, you can see the soft palate, but you can only see part of the uvula. Grade 3 and grade 4, you can only see the soft palate, whereas grade 4, the soft palate is not visible. How do we grade tonsillar grading? When we ask patients to open their mouth, if tonsillectomy has been done before, there's absence of tonsillar tissue, is graded as 0. Grade 1, the tonsil sits within the anterior and posterior pillars. Grade 2, it's extended beyond the pillars. Grade 3, it extended past the pillar to met nearly at the midline. And grade 4, it has touched the midline. And how do we screen patients with OSA? Screening for patients at risk for OSA is important as early detection will lead to early referral and also prioritization of patients who may need a diagnostic assessment. Several screening tools have been widely used in the adult population. I'm sure the commonly used one we've always been using before are the ones depicted in the diagram as above. So we have the Berlin questionnaire, stop bang questionnaire, stop questionnaire, and Epworth sleepiness scale. A meta-analysis have found that the sensitivity and diagnostic odd ratio of stop bank questionnaire were higher than Berlin questionnaire, stop questionnaire, and Epworth Sleepiness Scale. And it also have high sensitivity and diagnostic odd ratio to detect mild, moderate, or severe OSA. However, the specificity of stop bank questionnaire was lowered compared to Epworth Sleepiness Scale. Hence, the study concluded that stop bank questionnaire was superior in detection of various severity of OSA in adults compared with the other screening tools. So this table showed the pooled sensitivity and specificity. So this CPG has recommended that stop bank questionnaire should be used for screening of adults with clinical suspicion of obstructive sleep apnea. Epworth Sleepiness Scale may be used to assess the daytime sleepiness. After screening the patients, the next step is to diagnose OSA. The diagnosis of OSA cannot be made solely based on clinical signs or symptoms identified during history taking and examination. After screening tool has been carried out, OSA is diagnosed through polysomnography or sleep study test. There are different levels and different types of sleep tests. So level 1 is a full attended polysomnogram, which measures a minimum of 7 channels, which is EEG, EOG, EMG, ECG, airflow, respiratory effort, and oxygen saturation. In level 1, body position is measured, leg movement is measured, and it is an attended test where we have round-the-clock personnel to attend to the patient. Level 2 is full PSG, but it is unattended. So the difference is level 2 is an unattended but almost full channel sleep study. Level 3 is a portable monitor sleep study, or we call it partial PSG or HSAT, home sleep apnea test. There are minimum of 4 channels in this level 3 study, 2 respiratory effort and airflow, heart rate, and also oxygen saturation. Body position may and may not be measured. Leg movement is not measured, and this study is unattended. Level 4 sleep study is a continuous single or dual bioparameter with only minimum 1 channel, such as oxygen saturation and respiratory effort. In level 4 sleep study, body position are not measured and leg movement are not measured as well, and it is unattended. So what are the advantages and disadvantages of full PSG, which is level 1, or portable monitor, which is PM, or HSAT, home sleep apnea test, or the one that we label to as level 3 sleep study? So in a full PSG, the apnea-hypopnea index is defined as apnea-hypopnea per total sleep time, whereas in the home sleep apnea test, AHI is the number of apneas and hypopneas over total recording time, because we cannot measure whether the patient is asleep or awake because there's no EEG measured in this home sleep apnea test. So the disadvantages of a full PSG is there's a longer waiting time to do the study, as we have limitation in resources. And also there's a first night effect because patients have to do it in a sleep lab. The advantages is we are able to evaluate the sleep pattern and also able to identify other sleep breathing disorders. In the home sleep apnea test, the disadvantages are there are inability to evaluate the quality of sleep and other non-respiratory sleep disorders, as there are limited channels in this study. We can also underestimate the severity of the respiratory events compared with PSG. However, the great advantages of home sleep apnea tests are patients are sleeping in his or her own bed. So there are no first night effect, and the sleep pattern may be more representative of their everyday sleep. It also reduces the healthcare costs and waiting times as it can easily be done at home. So how do we diagnose OSA after we have put the patient on the sleep test? The followings are recommended for a diagnosis of OSA in adults. PSG or home sleep apnea test can be used in uncomplicated cases presented with signs and symptoms of OSA with increased risk for moderate to severe disease. Full PSG should be performed if a single home sleep apnea test is negative, inconclusive, or technically inadequate. Polysomnogram should be used for patients with significant cardiorespiratory disease, potential respiratory muscle weakness due to neuromuscular condition, awake hyperventilation or suspicion of sleep-related hypoventilation, chronic opioid medication use, history of smoking, or severe insomnia. A second PSG may also be considered if the initial PSG is negative and the clinical suspicion for OSA remains. In a meta-analysis on diagnostic accuracy of 19 high-quality studies, level 3 portable sleep tests when compared with level 1 PSG showed a good diagnostic performance in adults with uncomplicated OSA and no comorbidities. So our CPG opines that in patients with suspected OSA, the PSG should be performed within 6 months of initial consultation. Scoring of PSG should be performed by trained medical personnel and its interpretation should be verified by trained specialists. These are the diagnostic criteria for adult OSA in the CPG. It has to satisfy A and B or C. So A is the presence of one or more of the following, which is the patient complains of sleepiness, non-restorative sleep, fatigue or insomnia, and the patient wakes up with breath holding, gasping, choking. Bed partner observes habitual snoring and breathing interruptions, and the patient has been diagnosed with hypertension, mood disorder, cognitive dysfunction, coronary artery disease, stroke, heart failure, atrial fibrillation, or type 2 diabetes mellitus. Criteria B, PSG or out-of-center sleep testing demonstrates more than 5 predominantly obstructive respiratory events, which is obstructive and mixed apneas, hypopneas, or respiratory effort-related arousals, or what we call RERAs, per hour of sleep during a PSG or per hour of monitoring. Or criteria C, if the patient has PSG which showed 15 predominantly obstructive respiratory events, which is apneas, hypopneas, or RERAs per hour of sleep during a PSG or per hour of monitoring, they can be diagnosed as having OSA. So the third edition of the International Classification of Sleep Disorders, ICD-10-3, defines OSA as AHI of 5 or more per hour associated with the typical symptoms of OSA or associated medical or psychiatric disorder, AHI of 15 or more per hour even in the absence of symptoms or disorders. With this diagnosis, we can also stratify the severity of OSA. AHI of less than 5, the patient has no OSA. If it's 5 to 15 per hour, mild OSA. 15 to 30 per hour, moderate OSA. And more than 30 per hour is severe OSA. So in terms of diagnosis of OSA, this CPG recommends OSA should be diagnosed using PSG, either level 1, 2, or 3. PSG should be offered to patients with suspected OSA and completed within 6 months of initial consultation. Scoring of PSG should be performed by trained medical personnel and its interpretation should be verified by trained specialists. After screening and diagnosis, we should go on to treatment. Before I move on to treatment, there's a topic that I would like to touch, which is upper airway assessment. Upper airway assessment is important in deciding the best surgical approach to treat OSA. And how do we assess upper airway assessment? It's usually done by our ENT colleagues by doing a fiber optic nasal endoscopy with Muller's maneuver, FNMM, as a method to assess upper airway obstruction. 3 cross-sectional studies showed that there were discrepancies between Muller's maneuver and also the increasing popular method, which is drug-induced sleep endoscopy. So comparing these two, there were significant differences in detection of retrolingual collapse when compared with DICE compared with flexible nasal endoscopy Muller's maneuver. So we recommend that if DICE is unable to be performed prior to surgery, fiber optic nasal endoscopy Muller's maneuver may still be offered as an alternative procedure to identify the level and degree of obstruction. Moving on to treatment strategies in OSA. In OSA, we have divided our treatment strategies into different groups. Firstly, it's weight management and lifestyle modification, education, supportive and behavioral intentions, positive airway pressure therapy, surgery, and also adjunctive therapy. We cannot run away from weight management and lifestyle modification, as it's the prime treatment in treating OSA. Obesity is strongly associated with OSA, and there is a potential reciprocal role of obesity in OSA. 3 meta-analyses showed that lifestyle intervention, which include diet, exercise, or combination of both, has improved AHI and BMI in adults with OSA. PEG therapy refers to the delivery of compressed air which splints the collapsed upper airway. It is the gold standard treatment for OSA. There's 2 types of positive airway pressure therapy, which is CPAP and BiPAP, which can be automated or fixed pressure. CPAP or APAP is strongly recommended in the treatment of OSA in adults. How does the CPAP work? So in obstructive sleep apnea, during sleep, gravity and muscle relaxation will allow the tongue and surrounding soft tissue to fall back into the throat, hence obstructing the airflow and causing apnea. So with CPAP therapy, it opens up the airway and the tongue is prevented from falling backwards, and hence the patient will have no apnea and also no snoring. So in this CPG, we recommend that lifestyle intervention for weight reduction should be advocated in all patients with OSA. Positive airway therapy should be offered to patients with OSA upon diagnosis, especially in moderate to severe OSA. And nasal mask is the preferred interface. How do we monitor patients on PEP therapy? Monitoring of OSA cases are important to ensure treatment response, and also the side effects of PEP therapy is addressed. So treatment response of PEP therapy can be obtained from their usage data. Compliance of PEP therapy, they should be able to use daily more than 4 hours and should achieve more than 80%. So how about the success rate when they use the CPAP? So there's a reduction in AHI. So there should be AHI of less than 5 for at least 15-minute duration of supine REM, AHI less than 10 or reduction by 50% if baseline AHI less than 15. And also if they reduce the AHI 75% from baseline is considered adequate. And we also need to address the leak that they have from the mask. In addition to assessments of treatment effectiveness, AASM also recommends addressing issues with PEP therapy other than leakage, which is eye irritation, claustrophobia, skin irritation, having sore nose, stomach bloating, nasal congestion, dry mouth or throat, and also chest or lung infection. This algorithm of management of OSA patient in adults is in the CPG as depicted in algorithm 1. So when patients has been diagnosed with OSA with AHI score of more than 5, we should advocate lifestyle modifications and also put them on PEP therapy plus minus surgery. Surgery is for patients with intolerant or non-compliant to CPAP. So touching into surgery now, surgical management follows the algorithm as in the CPG, which is algorithm 2. We have to emphasize that the gold standard treatment for OSA is CPAP. So indication of surgery is in selected non-obese patients with mild or moderate OSA, we may consider surgery as first choice. Second indication is for patients who refuse CPAP. And third is for patients who is intolerant or non-compliant to CPAP. In the CPG, it is depicted in algorithm 2, where patient is intolerant or non-compliant to CPAP. If the BMI is more than 35 kg per meter squared, we do refer them for bariatric surgery. If it's less than 35, we can assess the dentofacial deformity. And the 2 main departments that we refer to for surgical assessment is ORL or oral maxillofacial surgeons. Referral to bariatric surgeons is for patients with BMI 35 or more. They are not for ORL or oral maxillofacial surgical intervention yet. So in this patient for surgery, upper airway surgery may be considered in selected group of OSA patients. A follow-up PSG may be considered 3 months after surgery. Follow-up for patients after surgery. How do we measure the success? Surgical success is shown by reduction of AHI more than 50% and or AHI is less than 20. Okay, so if post-op PSG after surgery still shows AHI more than 5, we should reconsider CPAP or continue the CPAP therapy. Moving on to adjunctive therapy. Adjunctive therapy in OSA includes mandibular advancement appliance and myofunctional therapy. Pharmacotherapy also has been found to be useful. It is used as an adjunct therapy in OSA patients with nasal obstructions and residual sleepiness. In a Cochrane systematic review, an RCT with moderate quality showed that intranasal fluticasone in OSA patients with allergic rhinitis significantly reduced AHI compared with placebo. Some OSA patients may have residual excessive daytime sleepiness even after using CPAP as first-line treatment. A meta-analysis showed that both modafinil and R-modafinil improve subjective based on ESS and objective based on sleep latency as measured by the maintenance of wakefulness test, daytime sleepiness in OSA compared with placebo. So in terms of adjunctive therapy, we recommend that mandibular advancement appliance may be considered for adult patients with obstructive sleep apnea. The preferred design should be tailored to the patient's conditions. In terms of pharmacotherapy, intranasal corticosteroids may be prescribed to OSA patients with symptoms of allergic rhinitis and chronic rhinosinusitis. So in a nutshell, if we want to summarize the treatment strategies for OSA, lifestyle intervention for weight reduction should be advocated in OSA. PEP therapy should be offered to patients with OSA upon diagnosis, especially in moderate to severe OSA. Nasal mask is the preferred interface. Upper airway surgery may be considered in selected group of OSA patients. A follow-up PSG may be considered 3 months after surgery. Maxillomandibular advancement may be considered in certain patients with moderate to severe OSA. Mandibular advancement appliance may be considered for adult patients with OSA, and the preferred design should be tailored to the patient's condition. In obese OSA patients, which is BMI more than 35 kg per meter squared, bariatric surgery may be considered. In terms of follow-up of OSA to ensure adherence and optimization of medical risk factors, AASM recommends periodic follow-up to confirm adequacy of treatment via reduction of AHI, symptom resolution via objective questionnaires like Epworth Sleepiness Scale, treatment adherence via PEP usage data. OSA should be ideally managed by a multidisciplinary team consisting of respiratory physicians, ORL surgeons, oral maxillofacial surgeons, orthodontists, bariatric surgeons, and dietitians. Emphasizing again follow-up post-surgery, following a surgical procedure and appropriate period of healing, patients should be assessed using PSG or home sleep apnea tests. The patients should be assessed clinically on periodic basis since OSA may recur post-operatively. AASM also recommends follow-up PSG or home sleep apnea test can be considered after a 10 to 20% reduction or increase in weight and after at least 3 months of recovery following weight loss surgery. Referral for sleep medicine services. Referral for sleep medicine in Malaysia for the management of OSA are offered by multidisciplinary specialties, including respiratory medicine, ORL, and oral maxillofacial surgery and orthodontic. So patients with clinical suspicions of OSA with or without cardiometabolic risk factors and stop bank score more than 3 should be referred for diagnostic sleep tests. Surgical referral for alternative treatment options has been recommended for adult patients with BMI less than 40 who are intolerant or unaccepting of CPAP, BMI less than 40 and persistent inadequate PAP adherence due to pressure-related side effects, and also patients with major upper airway anatomic abnormality for PAP as initial therapy before considering upper airway surgery. So the take-home message from this topic is screening is important for early detection of OSA, especially in patients at high risk. This will lead to early referral and also prioritization of patients who may need a diagnostic tool. PSG should be offered to patients with suspected OSA. And how do we treat patients with OSA? Again, it's lifestyle modification, education, supportive and behavioral interventions, PEP therapy being the mainstay treatment for OSA, surgery, and also adjunctive therapy. I would like to acknowledge Dr. Rashida, Dr. Rosanna, Dr. Lalita, Associate Prof. Dr. Wanu Azrina, and Dr. Sharifah Tahira for their contribution in the slides today. So with that, I thank you.
Thank you very much, Dr. Farahani Hassan, for the insightful session on OSA in adults.